I am Naman Kothari, International Business Development Manager from Zealmax Innovations Private Limited. Today, we are gathered here to delve into an utmost importance topic, the use of bipolar hemiarthroplasty in intertrochanteric fracture neck femur. We are excited to have each one of you join us as we embark on this informative journey together. But before that, we would like to inform more about our company. Zealmax Innovations Private Limited, founded in 2006. We have proudly established ourselves as a leading manufacturer of orthopedic implants in India. Our journey has been driven by a team of dedicated, highly specialized orthopedic professionals, doctors, and engineers, all working tirelessly to restore the lost mobility. But our vision doesn't stop at Indian borders. We believe that good healthcare should know no boundaries. That's why we have expanded our reach to more than 70 countries worldwide and have become renowned orthopedic implants exporter in India. Quality is our promise and we don't compromise on it. Each creation at Zealmax undergoes rigorous trainings and testings and meet the highest standards, ensuring that you get exceptional and unbelievable results. Results that bring back the joy of pain-free life. Let's watch this small video so that you get a better gist about our company.
If you're in a medical field that deals with orthopedic implants, then life is a bit difficult. You probably buy your orthopedic implants from your local suppliers, and they are too expensive. And dealing with a variety of suppliers to get different types of implants is all the more complicated. So, why not try importing orthopedic implants? Now we know what you're thinking. Importing orthopedic implants might be a cheaper solution, but there's so much risk in ensuring quality and timely delivery of the implants. Apart from that, importing orthopedic implants takes a lot of work. Researching the suppliers, giving them your list of requirements, not finding all the implants you need from one single dealer, negotiating the price, ensuring that the implants gets delivered on time, and the list goes on. Well, that's why we at Zealmax Ortho have worked tirelessly for 15 years to ensure delivery of high-quality orthopedic implants. Zealmax Ortho provides you with an all-encompassing variety of orthopedic implants, ranging from trauma, spine, arthroscopy, maxillofacial, hip prosthesis, pelvic, hand and foot, external fixation, all in one place. Zealmax Ortho is your one-stop solution for importing orthopedic implants. Now, you probably have an international supplier that provides you with your implants. But what makes Zealmax Ortho different from those suppliers is the manufacturing process. Along with our manufacturing partners at Relife Ortho, we use a combination of robotic manufacturing process spread across 7,000 square meters, as well as human-focused quality checks to produce more than 1 lakh implants per month. Not only that, we're one of the very few companies that customizes implants based on your requirements, as well as offer branding the implants with your organization's logo. But what about the legal registration process for international exports? Well, we're glad to let you know that we have customized dossiers of regulations, certificates of analysis, all based as per your country's law and order. This makes your legal registration process all the more smooth. Our 15 years of experience in this industry has enabled us to create an automated and streamlined supply system. With the help of our ERP software, we make sure that the delivery of high-quality implants takes place on time. And if that is not enough, our dedicated sales team will follow up on your order, providing you with timely updates from the day we confirm your order to the day your package gets delivered. All you need to do is go through our website, click on Enquire Now, and we will take care of the rest. Don't believe us? Well, then our list of 400 plus clients and deliveries across 70 plus countries cannot be wrong about this. And if that is not enough, let us also mention that all of our implants are tested in the Brazilian labs. So, what are you waiting for? Call or text us on the below mentioned number and let us make your process of importing orthopedic implants easier and quicker.
So as you can see in the video that we are delivering to more than 70 plus countries and what are the procedures that we are following. So I hope this video was insightful as there was something for everyone. Ladies and gentlemen, it is now our privilege to introduce to our esteemed panel expert, Mr. Rutul Gandhi, renowned orthopedic surgeon with exceptional expertise in joint and revision joint replacement surgeries. Mr. Rutul Gandhi's academic achievements and professional accolades speaks volume about his dedication to the field of orthopedics. He holds an MS Ortho, a testament to his academics, excellence, and commitment to honoring his surgical skills. Mr. Gandhi's further enhanced his knowledge and skills by attaining prestigious international fellowship. He is a proud FAOS, having completed a fellowship in orthopedics in South Korea and France. Notably, Mr. Gandhi is also because a recognition of his fellowship in orthopedics from Italy and Germany. This diverse exposures to multiple healthcare systems and surgical approaches has undoubtedly shaped his approach to patient care, bringing a holistic and international perspective to his practice. Moreover, he has achieved the designation of FIMAS, signifying his fellowship in orthopedic from Greece. This rich international experience has undoubtedly contributed to his extensive knowledge of different surgical techniques and treatments modalities. He is a passionate about sharing his knowledge with the medical community and contributing to the betterment of the patient care. Today, we are honored to have Mr. Rutul as the key member of our panel. His expertise and dedication are sure to enrich our discussion for the use of bipolar hemiarthroplasty in the intertrochanteric fracture femur nail. Let us warmly welcome Mr. Gandhi and prepare ourselves to lean from his vast reservoirs of knowledge and experiences. So, Mr. Gandhi, yeah.
Thank you, Naman. Thank you for this great introduction. And I also thank Zealmax Ortho for inviting me to this webinar. It is my pleasure to share my knowledge and share some insights regarding the use of hemiarthroplasty in fracture intertrochanteric neck femurs. Now, before wasting any time, let us dwell into this topic and let us start our discussion related to management of unstable intertrochanteric fractures with the help of hemiarthroplasty. As we all know, this fracture is an extracapsular fracture. That means the capsule is still attached to the neck and head part of the fracture. And this is a very important point because that will be a key step in managing this type of a fracture by the use of hemiarthroplasty. It occurs in the region between the greater and the lesser trochanter of the femur, and it often extends to the subtrochanteric region. And it is part of the pertrochanteric fracture, which happens in and around the greater and the lesser trochanter. If we talk about the epidemiology, this is one of a very common fracture which happens in older age group and with a minimal or a low intensity fall as well. And so this, I hope that everyone would of you would have seen this kind of fracture in and out in your daily practice. But still, this being a very common fracture, we have yet not found a very good surgical knowledge or a good surgical management for this kind of fractures. And that's why there are multitude of implants and multitude of management for this kind of fracture. The incidence is common in older age group between 60 to 80 years of age because it is a osteoporosis related fracture, and it is more common in the female population because of the postmenopausal metabolism changes in bone and osteoporosis, which is more common in this kind of patients. Other factors which are associated with the IT fractures are advancing age, bedridden states like Parkinson's disease, other increased number of comorbidities, and osteoporosis, as we had already discussed. Now, understanding the pathoanatomy of the fracture is very important because that will help us to manage this fracture in a better way. So in this kind of a fracture, the distal fragment would ride up and it would overlap on the proximal fragment, and the femoral neck shaft angle is reduced. The deforming muscle forces produce shortening, external rotation, and varus position of the limb. If we look at the muscles acting on the proximal part of the femur, and in this kind of fractures, we would understand that the abductors would try to displace the greater trochanter laterally and proximally, while the iliopsoas would displace the lesser trochanter medially and proximally. And the hip flexors, extensors, and adductors would pull the distal fragment proximally. That's how the fracture would go into a displaced pattern, and it is very difficult to get it into a reduced position and keep it into a reduced position. Fracture stability is determined by the presence of the posteromedial bony contact, which acts as a buttress against the fracture collapse. And so it is very important to have this posteromedial connect while we are reducing and fixing the fractures. If we look into the classification of this kind of fractures, there are multitude of fracture classifications are there, but still we follow the Evans classification as well as the OTA classification, because that's how we'll be able to manage these fractures in a better way. So Evans classifies these fractures into 6 types: type 1 to 5 and a reverse oblique pattern. In type 1 and 2, it is a 2 fragment fracture only, but it is displaced in the type 2 while it is undisplaced in type 1. Type 3 and 4 are 3 fragment fractures, and type 4 is a 4 fragment, type 5 is a 4 fragment fracture. So type 3, 4 and 5 are the unstable varieties of the fracture, and which require multitude of management patterns or multitude of management modalities. If we look into the AO classification, AO has classified this fracture into A1, A2 and A3 types, and all these are again classified into subtypes of 1, 2 and 3. So if we look at the stability, from the stability point of view, 4 types are stable fractures, while 5 types are unstable fractures. And it is this unstable fractures which requires a modality which helps to stabilize the fracture, give patient a better mobility and a better outcome. That is important in this kind of fractures. So again, the unstable intertrochanteric fractures are the fractures which collapses despite the axial reduction with the help of medullary or the extramedullary implants. So the unstable fractures are the comminuted fracture of the posterior medial portion, reverse oblique fractures, transverse fractures, or a fracture with a large posterior medial fragment or a subtrochanteric extension. If this type of fractures are not managed properly, then this would increase the morbidity and mortality of the patients. And as multitude of scientific papers have suggested, that 1 in 5 or 20% of the patients, they die or they have a mortality rate of 20% within 1 year of this fracture management. So it is our main aim to give mobility, and earlier bedridden status needs to be taken out from the patient so that they can walk around and give mobility, so that we can give mobility to these patients. As Zealmax Ortho also believes in mobility of the patient, so we have used this webinar to understand how to treat this unstable type of fractures with the help of hemiarthroplasty. So this hemiarthroplasty is indicated in failed internal fixation, the candidates which are unsuitable for repeat internal fixations. A calcar replacement hemiarthroplasty is also needed, because if we look at the implant, there is this shoulder which is important to rest on the lesser trochanter. If the lesser trochanter is damaged in this type of fracture, which is commonly is, then we need to use a calcar replacing hemiarthroplasty. And primary prosthetic replacement in comminuted unstable intertrochanteric fractures has yielded up to 94% of good functional results. And so it is very important that we all understand when to use, and most importantly, how to use this kind of surgery to give a better mobility to these patients. So now we'll look at the video where we will discuss how to manage this kind of fractures and what are the tips that we need to see during this kind of surgical management. So there are certain steps which are different from the routine hemiarthroplasty which we do for the neck femur. So if you look into this fracture, because the lesser trochanteric support or the proximal femoral support is not there, the fixation of the implant is not very good. The normal implant is not very good in this kind of fractures, and this implant might go into retroversion, or it can also go distally and not give proper stability. If you look at the um, procedure, so instead of the routine approach where we remove the external rotators or we cut the external rotators, in this type of fracture, what we do is we go through the fracture fragments. That's how we are not damaging the muscle either anteriorly or posteriorly, and that's how we'll be getting more stability and we will reduce the chances of dislocation while managing this kind of fractures with the help of hemiarthroplasty. So as you see, this is what we use to fix the proximal portion and take it out. So now if you look at the video, what I'm trying to do is trying to feel the fracture lines and trying to open the fracture, and that's how trying to remove the head and the neck portion of this kind of a fracture. Now you can see that I have put the retractors uh, so that we can retrace or we can retract the two fragments of the greater trochanter. And now I'm trying to lever out the proximal head and neck part. Again, with the help of this instrument, what I'm doing is I'm fixing it into the head and the neck, and I'm using it to lever it all around and doing radial capsulotomy, because as we all know, the capsule is still attached to the proximal part. So what we'll do is we'll try to cut the capsule from all the different sides and we'll try to take out the head and the neck portion. As you can see, now the head and the neck are levered out. Now after dislocating, what we'll do is we'll again put it into the place and we'll try to measure the horizontal and the vertical offset. This is very important because we need to again recreate the horizontal and the vertical offset, so that what happens is the muscle tends to come into the normal places and we reduce the chances of dislocation. So here in this video, in these steps, I'm trying to measure the vertical and the horizontal offset, as well as I'm marking some fixed points through which I'll again, after putting the implant, I'll again measure whether I have recreated the horizontal and the vertical offset or not. So this step is very important to reduce the chances of dislocation. Once the fracture is levered out, what I'll do is the other steps are very fairly common. We take out the bone on the proximal part. We do entry and we prepare the femur. The common type of implant which I use in this type of fractures is a distal loading implant. It can be either cemented or uncemented depending on the anatomy of the distal femur and if what kind of implant will give a better fix. So as I said in this video, what I'm doing right now is again measuring whether the proximal and the vertical and the horizontal offsets have been recreated or not. And after once I have confirmed, this is a trial. So once I have confirmed, I'll put in the final implant and then I'll fix it. After fixing, it is again very important to put all the fracture fragments back to recreate the greater trochanter and to give that good adductor muscle sling so that it decreases the chances of dislocation. So what I have done is I have put drill holes through the implant and through the greater trochanter, and now I am putting the wires and fixing it. These steps are very important to get a better muscular junction or the muscular sleeve again reproduced back on the proximal femoral part. So it is very important to fix the proximal femur with the help of two wires. Put it in a end circlage of figure of 8, and after fixing, we need to check whether all that are rotating. As we can see in this video, now all the fracture fragments are rotating as a single part, and not and none of the part is moving independently of the other. There is also another part where what we do is we put a small piece of bone into the lesser trochanteric area and fill the canal with the cement and then put the implant. So in this with the help of this technique, we can also use the commonly available short stem cemented implants. So what will happen is, with the help of this bone fragment, it will again recreate the lesser trochanter, and this collar will rest on that bone piece, and that's how we'll get more stability. So if you can look at the video, now I'm reducing the fracture after putting the implant, the bone piece, and the cement. And now again, it is very important to recreate the sleeve of the adductors and the greater trochanter over the fracture fragment. So again, we'll use the wires to fix the fracture fragments in a figure of 8. 2 wires at least are needed, and figure of 8 and tightening of this wires are needed. And once we are happy with the fixation, once we see that all the fragments are moving in collision again together with one another, then we close it in layers, closing the tensor fascia lata, skin, and the subcutaneous tissue over it. So, coming on to rehabilitation, it is important that we make the patient mobile with this kind of surgery on the first day or the second day itself, and that is very important advantage of this kind of management, and that's how we give mobility to the patients faster, and we take the patients out of the morbidity which are associated with this type of fractures when managed with intramedullary or extramedullary kind of implants. So again, I like to thank Zealmax Ortho and Naman for inviting me to this very informative webinar. I would like to say again that Zealmax Ortho is promoting mobility of the patients, and that's why we have taken this topic where we can give proper mobility and reduce the mortality and morbidity of the patients who are suffering from unstable type of intertrochanteric fractures.
So that was a very insightful session by Mr. Rutul Gandhi, and we would like to ask everyone that you must, get forward and ask more questions about this particular session so that it becomes a very interactive session. We welcome all the participants to ask questions, share their thoughts, and engage in a fruitful discussions with our expert panel, including Mr. Rutul Gandhi. So if anyone has any questions, please feel free to ask that questions, and the questions which we are receiving in chat box, we'll be taking some of the questions and we'll be discussing about it. So I just received a question. So I would like to recite the question first. So, Mr. Gandhi, someone has asked, what is the role of bipolar hemiarthroplasty in managing complications or failed treatment of intertrochanteric fractures?
So, in my practice, what I have seen is that once the fracture fixation fails, it is very difficult to again recreate the anatomy of the fracture or recreate the anatomy of the proximal femur with the use of intramedullary and extramedullary implants. So, if we want to give good mobility to the patients, then I would like to manage this kind of patients with the help of bipolar hemiarthroplasty. And as I said, depending on the fracture type and depending on the bone loss, I would like to use an implant which is distal femur loading, either cemented or cementless. And then my third option would be to use a commonly used routine cemented bipolar implant.
That's great. That's great. So we have another question. How do you choose between cemented and uncemented bipolar hemiarthroplasty implants impact patient outcome in intertrochanteric fractures?
Okay, so rather than the fracture pattern or the fracture anatomy or classification, what is important is to look at the proximal femoral part, which is attached to the shaft. So if it is Peperowski type 1 and 2, which is like a V shape or a parallel type of a medullary canal, then I would like to use an uncemented type of a distal loading implant. But if it is not getting a good fit, if the patient is very much osteoporotic, or the type of femur is type 3, where the distal part of the femoral shaft is dilated compared to the proximal part, then I would like to use a distal loading cemented stem. But be aware that cement has its own complications and that can cause certain issues, and the hospital or the setup needs to be ready to manage this kind of complications related to the cement.
So, taking on another question from our chat box, how does bipolar hemiarthroplasty differ from other surgical interventions, intertrochanteric fractures?
Okay. So if it is a stable variety, then I would again go for a intramedullary or extramedullary kind of implants, because in that I am very much confident that the stability of the proximal femur is not hampered, and it will stay as it is until the fracture is healed. But if I'm not very much sure, or if I'm not very much confident about the stability of the fracture, then in that cases, I would like to use a bipolar hemiarthroplasty. And that's how I will be able to give mobility to my patients. I'll be sleeping peacefully at night after operating the patient. That I'll be confident enough that the patient would be able to walk from the second day. So that's my take on when to use what or how to manage stable compared to an unstable intertrochanteric fracture.
I also believe that the medical facilities has grown so much that nowadays, after every surgery, the patient can be taken for a walk, but they can start walking after 5 to 7 days. So that is one of the biggest achievements that medical industry has
Exactly.
gone into picture.
So what is important, I will again like to add a point that the patient who walks on the second or the third day, he feels more confident. He or she feels more confident, and he or she feels independence. That he and she can go to the toilet or the bathroom by herself. They can go to the kitchen and drink a glass of water rather than depending on someone else to do this daily routine course.
Yes, that's really insightful. I've seen my grandmom has been through this surgery,
Right.
but it was very long back.
Right.
So in that era, it was very hard for them to even walk after a month or two.
Exactly.
So
Exactly.
that has been very painful, and at the same time, you are not able to do your daily routines.
Exactly.
So that is very that is something which has medically evolved.
Yes,
I would say.
true. And I think that companies like Zealmax Ortho and all the other companies which are putting a lot of research and lot of efforts into developing more and more newer implants.
Yes.
And coming out with, as you said, your company is using robotics.
Yes.
To give us precise implants and precise things like this instrument set which we have. So that has given us a lot of confidence of doing this kind of surgeries in this type of fractures.
Surely. We have another questions coming up, and I would like to take some more questions. Is it possible to undergo arthroplasty on both hips simultaneously?
So if we are talking about this kind of a fracture, then yes, it is possible. If we are talking of a normal arthroplasty in both the sides, then yes, we do it on a regular basis too. But it is very uncommon to find a patient having an intertrochanteric fracture on both the sides together. Because as we said, this is a low intensity fracture, or it breaks the one side and not break the other side. That is very common. But breaking both the neck femurs together, it is very rare to see. But if you are asking about doing arthroplasty together bilaterally simultaneous, like a routine total hip replacement, both the sides simultaneously, that yes, it is very much possible, and we do it day in and day out.
So basically, it means to say that we can change both the
hip balls together.
Oh, that's great. Yeah. So what are the? There's another question I would like to take up. What are the indications and contradicting indications for using bipolar hemiarthroplasty in intertrochanteric fractures?
So if you can give a good stability with the help of intramedullary and extramedullary implants, then there is no fun in taking out of the normal proximal femur or the normal femoral head.
Yeah.
So that is one of the contraindication, I would say, is a stable type of fractures where the routine other implants can also give a good or equivalent results.
Perfect.
Coming on to the contraindications, if the patient is medically unfit, too much unfit, because this is a major surgery compared to an intramedullary or extramedullary implant. So this is kind of a major surgery. So if the patient is very much unfit to undergo the surgery, then it is better to use a less minimally invasive implants rather than this bipolar arthroplasty.
Okay.
And then all the other contraindications of total hip replacement stands true for bipolar arthroplasty also. So if the patient is having infection somewhere, if the patient is not fit for surgery, or if the patient is having local bad skin conditions, then I would not suggest to go for a bipolar arthroplasty in that kind of patient.
So there is another question. Do you use this kind of procedures for femoral neck fractures too?
Yes, it's very common. That is the first kind of fractures where these kind of implants were used. And we have a large, like as mankind or human race,
Yeah.
we have a large series and studies available that bipolar arthroplasty is the choice of treatment in older people having neck femur fractures. But using bipolar arthroplasty in intertrochanteric fractures is relatively newer, and still today there are many countries or many centers which are not able to accept this kind of treatment modality because they are not aware of it and they are not being trained to treat this kind of fractures. But we have now multitude of scientific papers, scientific journal publications, which suggest that giving mobility to the patient can help to decrease the mortality in this kind of in this type of patients.
Agreed. Totally agree. So I would like to take one last question. And what do you say about the status of acetabular, and is it visible to use for neglected IT fractures too?
So yes, if by after opening the fracture, if you see that the acetabulum is damaged because the acetabulum is right in front of you, if you have a slightest of the doubt that the acetabulum is damaged, and doing this arthroplasty would give then a pain of the acetabular erosions and acetabular osteoarthritis, then it is better to do a total hip replacement in this type of fractures. But be aware that total hip replacements are more probable to have dislocations in this kind of fractures because the muscles are also damaged. And whatever we do, whatever how much good refixation of the lateral fragments we do, still the muscle damage is still there due to the soft tissue edema and soft tissue damage. And this total hip replacements might dislocate, or the dislocation rates is higher when total hip replacements are used in intertrochanteric neck fractures.
So that was a great session. Thank you, Mr. Rutul Gandhi. I believe all the questions has been taken up, which has been discussed in chat, and that's how we are going to perform our webinars. And I would like to, finish or end this webinar on a greater note. Ladies and gentlemen, as we come to the end of the enlightening webinar, we would like to express our heartful gratitude to all the participants, our esteemed panel of experts, and especially to Mr. Rutul Gandhi for sharing his invaluable insights. As we conclude, we encourage you to continue the dialogue beyond this webinar. Stay curious, stay informed, and keep exploring new ways to enhance patient care and well-being. If you have any further queries or wish to access webinar content, feel free to reach out to us. We value your feedback and are committed to continuously improving our educational initiatives. Thank you and see you all in the next one. We are going to have our next webinar soon, so stay connected and be happy. Bye-bye. Take care.